Hola, buenos días, buenas tardes a todas y todos. Bienvenidos desde la sede de la Organización Panamericana de la Salud en Washington, D.C., a esta conferencia de prensa sobre la situación de COVID-19 en las Américas. Soy Luciana Viegas, asesora de Asuntos Públicos. Hoy es miércoles 9 de febrero de 2022. Y como todas las semanas contamos con interpretación en inglés, portugués y francés y podemos tomar y contestar preguntas en inglés, portugués y español, claro. Hemos recibido preguntas por correo electrónico y gracias a los periodistas que nos enviaron por adelantado, pero podrán también hacer preguntas en el botón Q y A. Recuerden identificarse con su nombre y el medio de comunicación al enviar las preguntas, por favor. Hoy la directora de la OPS, la doctora Carissa Etienne, nos pasará una actualización sobre la situación epidemiológica y también hablará sobre el impacto de la pandemia en los trabajadores de la salud. Acompaña a la doctora Etienne en la sesión el doctor Jarbas Barbosa, subdirector de la OPS, el doctor Ciro Ugarte, director en emergencias en salud de la OPS, y el doctor Silván Aldiguiere, gerente de incidente para COVID-19 en la OPS. Invito ahora a la doctora Etienne a nos compartir sus palabras de apertura. Dr. Etienne, please.
Thank you so much. A very warm morning to you, and let me thank you for joining today's press briefing. While still very high, new infections and hospitalizations are beginning to go down in some countries in our region. Cases decreased by 31% as compared with the previous week. Deaths, on the other hand, increased by 13% overall, with higher increases in parts of Central and South America. Last week, we saw more than 4.8 million new cases and over 33,000 new deaths in our region. In North America, new infections and deaths decreased in the 3 countries, while hospitalization and ICU admissions decreased in the US and Canada. Across Central America, deaths increased by nearly 30% overall, but cases are beginning to slow across the subregion, with new infections in El Salvador dropping by 70%. In Belize and Panama, new cases dropped by over a third. Infections are also slowing in parts of South America. Cases were cut by half in Peru and Argentina, but deaths continued to rise across the region, ranging from a 9.4 rise in Bolivia to a 42% increase in Venezuela. Hospitalizations are rising in most southern cone countries, with a 50% rise in Chile. The Caribbean is also seeing new cases slow, while deaths continue to climb, except for a few countries. Infections increased by 88% in Dominica over the last week, and they continued to rise in St. Vincent and the Grenadines. When we look closer, one trend stands out, and that is countries with higher vaccination coverage are seeing lower ICU admissions and deaths. This emphasizes the importance of expanding access to vaccines, including boosters where available, to save lives. When cases surge exponentially, as they have in the past few weeks, the burden falls mostly on the people that power our health systems. For them, there is nothing mild about the Omicron wave. As part of PAHO's efforts to support health personnel in the Americas, we've been closely tracking the pandemic's effect on our region's health workforce. We've released a new report this week that describes the challenges that our frontline workers have faced and effective policies to help protect them. This data complements other studies that PAHO has led on the mental health of our health workers. Today, I want to share a few lessons and key takeaways from these analyses. The first is that, especially at the beginning of the pandemic, health workers were caught off guard, and our health systems were unprepared to support them. Doctors, nurses, and other frontline health workers saw more patients and worked longer hours than ever before. They were vulnerable to a new virus, and without sufficient masks, gloves, and other personal protective equipment, suffered high rates of COVID infection. In Ecuador and Bolivia, more than 1 in 10 healthcare workers got COVID. Even before the pandemic, the health workforce in the Americas faced serious disadvantages that were only exacerbated by COVID. Years of underinvestment in our health services, aging information systems, and poor labor conditions made our health workers' job even more challenging. The pandemic revealed a deficit in the availability of health workers, uneven distribution of health workers across our countries, and inadequate training. Many health workers were at risk of burnout. According to the Collaborative Heroes study, in 11 Latin American countries, health workers showed elevated rates of depressive symptoms, suicidal thinking, and psychological distress. In Chile, more than 1/3 of all health workers experienced a depressive episode, and nearly 15% of the medical workforce had thoughts of suicide. In Brazil, Guatemala, and Colombia, more than 1 in 10 doctors, nurses, and community health workers experienced symptoms of severe depression. And while these numbers vary by country, they gave us a sense of how dire the situation was across the region. So 2 years later, we have learned many lessons on how to better support our health workers, especially how planning and investments can make a big difference. Through our study in Bolivia, Chile, Colombia, Ecuador, and Peru, we gathered examples of best practices that are echoed throughout the region. Securing essential protective equipment like masks, gloves, and gowns was critical to enabling health workers to do their jobs safely. PAHO worked to secure and ship these supplies to countries in our region. Vaccines have also made a big difference in protecting our health workers, and we've been pleased to see that many countries gave health workers priority in accordance with PAHO's recommendations. By recognizing the extra risks health providers face from COVID in the workplace, some countries paved the way for new policies like hazard pay and life insurance to recognize health workers for their efforts. Colombia and Chile prioritized regular testing for healthcare workers, and they transitioned many older and pregnant staff to telemedicine work to protect them from infection. Some places also revamped medical education to grow the cadre of motivated, well-qualified health personnel. As countries continue to face the latest Omicron wave, these lessons must guide us as clinics and hospitals once again become full. Now more than ever, we must ensure that health workers are protected with life-saving COVID-19 vaccines and receive priority for vaccine boosters where available. While many places are doing this already, in Belize, Argentina, and St. Vincent and the Grenadines, more than 40% of healthcare workers have yet to receive their second dose of vaccines. Countries should also reevaluate their staffing needs and hire more qualified health personnel, placing them where the largest gaps are. They should follow the best practices that I outlined earlier, like modifying work environments to guarantee adequate working conditions, providing decent salaries and fair contracts, and creating spaces where teams can talk and engage in self-care practices. As countries expand and update their workforce, they can count on support from PAHO's virtual campus for public health, a learning platform where health workers can take a variety of courses and build on their skills to better face this pandemic. More than 1.7 million health workers have already participated in training on the virtual campus, and 40,000 new medical personnel are joining every month. All these actions will remain critical, even if the pandemic's acute phase winds down, because investing in our health workforce should not be something that countries only do during an emergency. Many of these changes can and should be made permanent. Healthcare workers are all frontline against COVID and against every other health risk that we face in our lives. They hold the key to protecting our communities today and as we face new health crises and challenges. We must always protect and care for our health workforce, because investing in our health workforce is an investment in all of us. Thanks.
Thank you, Dr. Tien. Pasamos a las preguntas. Empezamos con una pregunta que creo es frecuente en el momento, a question that is in a lot of people's minds. Two examples we received. Hannah May Nasser, reporter from City News, Vancouver, Canada. What exactly is needed for a pandemic to be considered endemic, and what does it mean? And a similar question we received from Camille Strachnoi from TELAM, the National News Agency of Argentina, saying the UK government announced today that it intends to end all restrictions as a strategy for living with COVID. What is our opinion about this view that is growing in Europe of going from pandemic to endemic? Dr. Tien?
So thank you, Hannah and Camille, for this very important and I think very relevant to our time question. The COVID-19 pandemic began, as you know, at the end of 2019 and has since spread to every country in the world, causing more than 5.7 million deaths and infecting over 394 million people. The main characteristic of this pandemic remains the uncertainty of its evolution, and this requires some caution. New variants of concern can emerge and change completely the COVID-19 epidemiological profile, and we've seen this already. While it is possible that SARS-CoV-2 virus will eventually become endemic, we think that this can take some years. Unfortunately, we expect to see new epidemics or large outbreaks even in areas with high vaccination coverage, especially where public health and social distancing measures are relaxed. Vaccination is reducing the severe disease and death from COVID-19, but let's remember, not transmission. There is no established definition of what an endemic COVID-19 would be or would look like. Endemic simply means the continued presence of a disease in a population or area, perhaps with a constant burden over time. Other respiratory viruses of public health importance, such as influenza and respiratory syncytial virus, they occur in epidemics with a strong seasonal character in the temperate areas and a more difficult to predict pattern in tropical and subtropical areas. We believe that public health and social distancing measures remain an important tool that must be modulated according to epidemiological developments and capabilities within countries, and all of these remain uncertain. So this is true in all countries, but it is even more important in countries and areas where vaccination coverage remains low or mixed, where there are significant risks of a high rate of severe disease and mortality. We say often it is country specific. Thank you very much.
Thank you, Dr. Tien. We go to the next question, somewhat related, from Naomi O'Leary from the Irish Times. Naomi asks, I would like to understand what stage of the pandemic we are now at. Where are the hotspots globally? And what does the management of COVID look like going forward, especially as public support for intervention seems to have declined? And finally, she asks, is Omicron truly less dangerous? And what are the risks of a more deadly variant emerging? Dr. Aldegheri?
So thank you for this question. And as you said, Dr. Etienne has already tackled some of these aspects. But first point, where we stand as of today, we can say that as for the previous waves in 2020 and 2021, the European and American regions are currently the most affected areas of the pandemic in terms of number of cases and number of deaths. During the first week of February, the region of the Americas has reported 4.8 million new cases, including 33,000 new deaths. I'd like to stress that even we are observing a decrease of new cases region-wide, we are still seeing an increase in death, with 13% more death during the first week of February compared to the last week of January. This increase in death is clearly observed in both Central America and North America. And the delay in the increase in death compared to the increase in cases is expected and has been observed throughout the pandemic. It reflects the clinical course of the disease in sick people. Now, regarding the aspect of your question regarding the management at this stage of the pandemic, there are no predefined stages in managing pandemics. This was actually a lesson learned from the 2009 influenza H1N1 pandemic, when such pandemic phases were more a hurdle than an help. Today, we manage pandemics based on an ongoing assessment of risk and consequent adjustments of the possible measures. At this moment of the pandemic of COVID-19, we are probably on the down slope of a global wave caused by Omicron. However, highest rates of cases are still reported across Europe, North America, and South America. Omicron, like any other variants, is best described in terms of two characteristics: transmissibility and severity. While Omicron is probably somewhat less severe, that is offset by a much greater transmissibility. So if you have lots of cases which have a relatively lower likelihood to become severe, you still have, in the end, significant impact, which is exactly what we are observing in the Americas. Now, I'd like to include the aspect of the clinical management. The fundamentals of patient care and the use of clinical diagnostic and treatment for COVID-19 have not changed with the emergence of the Omicron variant. And PAHO is assisting countries to continually improve the standard of care and access to treatments and diagnostics. Now, regarding the risk of emergence of new variants, what we can say is that the emergence of a number of variants of concern has been a driver of the pandemic since late 2020. The emergence of additional variants, new variants, is possible and would continue to drive the pandemic during the coming months or years. If additional variants were to emerge, we cannot anticipate whether they would be more or less severe and transmissible. And this is an uncertainty we have to work with. This is the reason why we are closely following the evolution of the behavior of SARS-CoV-2 throughout the genomic surveillance in order to timely detect mutations that might be related to changes in clinical patterns or any impact in public health interventions, including vaccine efficacy. So thank you. I hope that I have answered all the aspects of the question from the Irish time. Over.
Thank you, Dr. Aldigueri. Pasamos a dos preguntas desde México. Melina Ochoa, de 1TV en Ciudad de México, pregunta la primera pregunta. Ayer el canciller mexicano, Marcel Ebrard, anunció que México recibirá 18 millones de dosis de la vacuna AstraZeneca a través del mecanismo COVAX en este mes de febrero. La OPS tiene la fecha para la llegada de estas dosis al territorio mexicano. Doctor Barbosa.
Gracias por la pregunta, Melina. Sim, efectivamente, México todavía tiene un remanente de vacunas para recibir de COVAX y el gobierno de México, que antes hacía los arreglos directamente con el mecanismo COVAX, ahora solicitó a la OPS que pueda hacer la entrega de esas vacunas. Entonces, ya estamos en contacto con las autoridades de México y con los productores para todos los arreglos legales y administrativos. Esperamos que eso pueda estar concluido en un par de días. Y después que se hace la firma y la conclusión de la solicitud de compra, eso toma 1 o 2 semanas para empezar la entrega de las vacunas. Por la cantidad, que es muy importante, 18 millones, muchas veces se tiene que enviar en distintas entregas al país. Pero va a ser un refuerzo importante para la vacunación en México, que hay importantes progresos en los últimos meses, y con esas nuevas 18 millones va a tener más vacunas para ofertar a su población. Gracias.
Gracias, doctor Barbosa. Melina tiene una segunda pregunta. Por otro lado, el subsecretario Hugo López-Gatell informó que continúan a la baja los casos de COVID-19 en el país y lo más probable es que la trayectoria se mantenga de esta forma hasta su completa reducción o desaparición. La OPS ve esta misma tendencia en México. Y por último, ¿en qué porcentaje la variante Omicron circula en México? Doctor Aldigueri.
Sí, gracias por esa pregunta. En México, como en la región de las Américas, se observa una tendencia marcada a la baja de nuevos casos. En México, esa semana, el número de casos activos pasó de casi 208.000 a 125.000, o sea, un descenso de 40%. En este contexto, OPS sigue recomendando la mayor prudencia y cautela a corto y medio plazo, dado que se sigue observando un alto número de casos nuevos en países de la región, como en México. Y quisiera de nuevo repetir mis comentarios a la colega del Irish Times. Es que durante la primera semana de febrero, la región de las Américas ha reportado 4.8 millones de nuevos casos y más de 33.000 fallecidos. Y quisiera destacar que aún hemos observado un descenso de casos a nivel regional. Estamos todavía observando un incremento de los fallecidos con un 13% más durante la primera semana de febrero, comparado con la última semana de enero. Y este aumento de número de fallecidos se refleja de manera muy clara en América Central y en América del Sur. En lo que corresponde a la variante Omicron, a través de la red regional de vigilancia genómica coordinada por OPS y, por supuesto, el trabajo muy intenso de los países, incluyendo los 8 laboratorios regionales de referencia. Hasta enero de 2022 se han reportado a la plataforma global llamada GISAID aproximadamente 262,000 secuencias completas del genoma del virus en América Latina y en el Caribe. Y gracias a esa información sabemos que la variante Delta fue predominante en todos los países de América hasta mediados de diciembre. Sin embargo, desde la introducción de la variante Omicron en las Américas se está extendiendo rápidamente y hasta el día de hoy ha sido informada oficialmente y reportada por 48 países y territorios en nuestra región. La variante Omicron siendo predominante en todas las subregiones de las Américas. Particularmente en México, y de acuerdo con los datos reportados por la Red Nacional de Vigilancia Genómica, que está liderada por el INDRE, durante las 2 primeras semanas de enero de 2022 se ha detectado la variante Delta en un 5% de las muestras, mientras que Omicron fue detectada en el 95% de las secuencias. Sin embargo, para el 31 de enero, el 100% de las secuencias fueron identificadas como Omicron, siendo entonces predominante en México como en el resto de la región. Espero haber respondido a todos los aspectos de las preguntas de UNO-TV. Gracias.
Gracias, doctor Aldigueri. Pasamos a una pregunta del Caribe. Kadim Joseph at Observer Media in Antigua and Barbuda asks, Antigua and Barbuda has elected to allow residents to import their own COVID rapid test kits as we continue to monitor the pandemic. Are mechanisms necessary to ensure that individuals who test positive with these kits report or get a follow-up PCR test? Or will self-regulation become the new normal in COVID-19 management? And a second question, are countries still required to report all confirmed positive cases? Dr. Ugarte?
Thank you. Thank you, Luciana. Thank you, Kadim, for those questions. Diagnostic testing for SARS-CoV-2 is a critical component of the overall prevention and control strategy of this pandemic. But tests should be reliable, affordable, accessible, and provide results rapidly to ensure appropriate clinical care and support for patients, and of course, inform actions to prevent transmission in the community, inside the families and the neighborhoods. PAHO does not recommend self-testing, as there is not strong evidence so far indicating that a real impact in the transmission of the virus, and the cost effectiveness should be evaluated constantly. We are not aware of a new policy for individuals to import their own test kits. However, it is encouraged to decentralize testing and use new testing strategies based on national conditions. On the other hand, depending on the surveillance strategy implemented on each country, reporting every case is required to closely follow the dynamic of the epidemic. And that may not be easy if a self-testing strategy is implemented, particularly because it is associated with a condition that the persons who are tested positive are stigmatized and probably suffer more than the disease itself. Nevertheless, this is a dynamic situation, and the strategies might be adapted depending on the behavior of the virus and the epidemiological conditions. In any case, self-care and individual responsibility continues to be the main public health measure. And implementing each country that self-care and public health measures remain critical to slow transmission and control the pandemic. At the same time, good laboratory practices that produce accurate COVID-19 results are key to assure that laboratory testing benefits the public health response. We are aware that there is a huge demand of testing in many countries. And in that regards, we know that in Antigua and Barbuda and many other countries, there is this huge demand has resulted in a larger than 48 hours turnaround of testing. And of course, it affects also all the capacity that they have to, the laboratories have to process the samples and to make the results available to the public. So in that regards, it is very important that in the areas where there is community transmission, we must make all the efforts to identify the positive cases in a context that probably the availability of those tests will not be for everybody, including the non-symptomatic persons. So this is a must, and the prioritization should focus on reducing transmission and the early identification of the cases, so the public health measures will be taken accordingly. Thank you.
Thank you, Dr. Ugarte. Pasamos a una pregunta del periódico Estadão de Brasil. Carolina Marins pregunta: en la última conferencia la semana pasada, la doctora Carissa Etienne citó puntos ciegos graves en los datos de vacunación en la región y por lo tanto se desconoce la disparidad de vacunas en las Américas. Carolina pregunta: ¿es posible señalar cuántos y cuáles son estos países que no tienen datos detallados de sus vacunas? Doctor Barbosa.
Gracias, Carolina, por la pregunta. Mira, todos los países de la región están enviando los datos de vacunación para la OPF. Todos los viernes recibimos de todos los países y territorios de la región estos dados que están bien detallados por vacuna que se aplica, cuál es la cantidad, cuál es la cobertura de vacunación. Esto está en un tablero, que es un tablero público de la OPF que usted puede consultar. Pero ahí tenemos el promedio de la cobertura de vacunación en cada país. Y lo que la directora tiene la intención de subrayar cuando habló de los puntos ciegos es que el promedio de un país no es suficiente. Todos los países de la región tienen que trabajar con datos subnacionales, porque la misma inequidad que tenemos muchas veces en la cobertura de vacunación entre países, también tenemos al interior de un país, con estados con una cobertura bien más importante que otros. Eso pasa en muchos países de la región. Tenemos también inequidad en términos de algunos grupos poblacionales, por ejemplo, los grupos, las poblaciones indígenas y otros grupos que pueden tener, por dificultad de acceso a los servicios de salud, uma cobertura mais baixa. Também é muito importante monitorear por grupo de idade e a diferença entre a primeira dose, a segunda dose e a dose de reforço, porque muitas vezes as pessoas não estão completando todo o esquema de vacunação, que é essencial para que possam se quedar protegidos. Assim, é um chamado a que os países possam perfeccionar os dados que têm e aí poder identificar estratégias adequadas para que todos os níveis subnacionais, todos os grupos poblacionais tenham a mesma cobertura de vacunação e também verificar onde é necessário adotar estratégias específicas para aumentar a cobertura de vacunação. Ou seja, todos os países da região têm que fazer esse esforço. A OPS brinda a cooperação técnica e está trabalhando com muitos países para fazer esse tipo de análise mais detalhada, mais específica, pero que é muito importante para que a vacinação possa ser cada vez mais efetiva em la prevenção de muertes, de casos graves e apoiar o próprio controle da pandemia. Muitas graças.
Gracias, Dr. Barbosa. Pasamos a más una pregunta del Caribe. Ariel Bowleg from the Tribune in the Bahamas. asks, globally, there have been talks of starting to coexist with the virus. The government of the Bahamas is considering relaxing restrictions as COVID-19 cases and hospitalizations continue to decline. A local senior physician has said that it may be time for officials at the Ministry of Health to begin discussions about easing restrictions. 2 years of the pandemic, are we at a point to start coexisting with the virus, or should we not let our guard down and wait until we're fully out of the pandemic? That's question one. Second, currently a number of hotels in the Bahamas are having large concerts for international artists, despite the Ministry of Health disapproval. What threat does it pose, even if the event organizers have testing and require proof of vaccination? What does PAHO suggest to tackle this problem? Dr. Ugarte, for you, maybe those two questions.
Thank you, Luciana. Thank you, Ariela. We have been mentioning several times that each country must consider a proper balance between population health and well-being and progressively reestablish all sectors' activity to recover their economies. In that regards, a close coordination between corresponding authorities is needed to make the best decisions in a context of the current pandemic, where we see a sharp increase of cases when we relax the public health and social measures. It is important to consider the current epidemiologic situation, as we said, the current capacity of the health services, particularly ICU beds and hospitalization beds, and the vaccination rates to decide which restrictions may be relaxed and at what level. A good operational monitoring system is a must when we adopt any relaxation of measures, in order to early identify a surge of cases, localized surge of cases, and prevent community transmission. And accordingly, all the measures must be adjusted with those monitoring information, with that monitoring information. We are aware that in the Bahamas, there is a good process to approve large concerts and gatherings. The organizers request approval from the Ministry of Health, including all the plans that they have, and the Ministry of Health provides advice and guidance to the organizers to implement the proper measures. And if those measures are well established in order to reduce the transmission in those gatherings, the Ministry of Health may approve those events. But also we are aware that some organizers decide not to request the Ministry of Health, and they decide to organize those events. In those situations, we saw that the Ministry of Health itself, according with other authorities, went to those events and even had to stop the public from attending such events. So that is a very good policy. The organizers of gatherings of public events not only will show responsibility when they request authorization, but also they benefit from the advice of the Ministry of Health. In that regard, everybody wins. So we encourage the organizers of such events to be fully aware of the public health measures in place at the current situation in the current location, and follow always the public health measures established by the country. Thank you.
Thank you, Dr. Ugarte. Pasamos a una pregunta sobre las vacunaciones en Latinoamérica. Matías Lowy, Medscape en español, pregunta: ¿Latinoamérica es la región del mundo con más vacunas contra COVID-19 autorizadas por país, con 1/3 de los países que tienen 7 o más vacunas registradas? En Europa esa proporción es de apenas 5%. Interpretan que la diversidad de vacunas contrato es un factor positivo para asegurar niveles de cobertura o no necesariamente. Doctor Barbosa.
Gracias por la pregunta, Matías. Mira, el proceso de licencia, de registro de una vacuna empieza con el productor. o produtor é que tem que tomar a iniciativa. Não é uma decisão de um país, eu vou autorizar esta ou aquela vacuna. O produtor tem que buscar a autoridade regulatória do país, apresentar um dossiê com todos os dados que confirmam a qualidade da fabricação da vacuna, os resultados dos ensaios clínicos de fase 1, 2 e 3, que comprovam que essa vacuna é segura e é eficaz. Só depois é que empieza o processo de avaliação das autoridades reguladoras de cada país. Esse número maior de países que temos em América Latina com mais vacunas licenciadas que alguns países da Europa, eu creio que refletem, primeiro, a disponibilidade ou a falta de disponibilidade de algumas vacunas ao princípio da pandemia. Tivemos alguns produtores que, por razões de mercado, buscaram mercados mais fortes, que estavam já listos para comprar suas vacunas e apresentaram primeiro, sempre apresentam primeiro em los países que têm interesse de vender a vacuna. Muito por razões de mercado. E nessa situação, muitos outros produtores buscaram países da América Latina para apresentar seus produtos e receber também a licença. Seguro que quando um país tem mais vacunas disponíveis, pode utilizar uma diversidade de vacunas e hoje há estudos muito importantes que demonstram que se pode utilizar 2 vacunas, por exemplo, para a vacunação primária com uma vacuna e a terceira dose ou reforço com uma outra vacuna. Há muitos estudos que demonstram isso. Então, sempre é uma maior oportunidade. E a OPS tem trabalhado desde o princípio da pandemia para fortalecer a capacidade das autoridades reguladoras em los temas para a pandemia. Tivemos mais de 30 reuniões com as autoridades reguladoras sobre muitos temas, os testes, os medicamentos, as vacunas, para que possam fazer uma avaliação que garantize o acesso ao mesmo tempo que possam revisar bem a qualidade, a segurança e também a eficácia desses produtos. Assim que é reflexo, eu creio, do mercado. Também é importante notar que em Europa, Europa tem uma autoridade regional, a Autoridade Europeia de Medicamentos, a EMA, por seu acrônimo em inglês. Então, também muitos produtores apresentam solo para a EMA porque não necessitam apresentar em cada um dos países. Então, há essa diferença, pero eu creio que, em geral, ter mais vacunas disponíveis pode ser uma vantagem desde que o país tenha condições de manejar bem os distintos esquemas que isso pode trazer para seu programa de imunizações. Gracias.
Gracias, doctor Barbosa. Tenemos 2 preguntas sobre las mascarillas. Henry Cárdenas, de la prensa, Panamá, pregunta qué indicadores debe tomar en cuenta Panamá para proceder a quitar el uso de la mascarilla de forma obligatoria, partiendo de la experiencia de otros países. Y Gerson Collave, de El Comercio Perú, también pregunta, diversos países en Europa están retirando el uso de mascarillas en espacios abiertos. ¿Qué condiciones tendrían que darse en la región para que esto también suceda según la OPS? Doctor Garte.
Muchas gracias, Luciana, y gracias a los periodistas por sus preguntas. Bueno, respecto a Panamá, tenemos entendido que las autoridades no están considerando eliminar el uso de las mascarillas. Su uso adecuado en todos los países de la región y del mundo ha demostrado que es altamente efectivo para evitar el contagio de la COVID-19, pero también de influenza y de otras enfermedades que se transmiten por vía respiratoria. El Ministerio de Salud Pública de Panamá publica periódicamente recomendaciones y actualizaciones, incluyendo variaciones del uso de mascarillas en espacios abiertos y en prácticas deportivas. De tal manera que el monitoreo constante de esas medidas es necesario para poder considerar el uso o no de mascarillas en ambientes abiertos, en ambientes públicos, como algunos países en Europa han considerado. Si hay algo que hemos aprendido en estos 2 años de pandemia, es que cuando se han levantado las restricciones del uso de mascarillas, en pocas semanas se ha observado un incremento muy significativo de casos en todos los países que han adoptado esa decisión. De tal manera que es un contexto también dinámico y las condiciones de transmisión comunitaria y la disponibilidad de los servicios de salud y la cobertura de vacunación son los tres elementos fundamentales para tomar medidas, siempre con un monitoreo muy activo y con disponibilidad rápida de pruebas de diagnóstico para las personas que tengan sintomatología, de tal manera que podamos controlar brotes localizados y evitar transmisión comunitaria, como se ha presentado en otros casos. Gracias, Luciana.
Gracias, Dr. Ugarte. Temos uma pergunta desde Brasília, em português. Chloe Pinheiro, Veja Saúde, pergunta qual é a taxa de letalidade atual da Omicron? Existe uma taxa de letalidade que sinaliza a fase endêmica da doença? Dr. Barbosa, em português, talvez uma resposta, por favor.
Não, obrigado pela pergunta. E talvez um dos fenômenos que a pandemia trouxe é que termos de epidemiologia atualmente estão virando populares. Primeiro, deixe-me esclarecer o que é uma taxa de letalidade. A taxa de letalidade é um indicador que mede a gravidade de uma doença, ou seja, de cada 100 casos de uma doença, quantas pessoas morrem. Esse é um indicador, portanto, que ele é bom para doenças que nós temos uma contagem rigorosa do número de casos e do número de mortes, porque o número de mortes é o numerador e o número de casos é o denominador. Então, por exemplo, uma doença que de cada 100 casos, 2 morrem, tem uma taxa de letalidade de 2%. No caso da COVID-19, taxa de letalidade não é um bom indicador. Por quê? Porque o denominador, que é o número de casos, ele não é muito bem conhecido, porque grande parte dos casos é assintomático. As pessoas ou têm sintomas muito leves, então as pessoas não vão à unidade de saúde para receber o diagnóstico. Segundo, porque pode variar muito de um país para outro. Um país que tem mais condições de testar os casos e confirmar, vai ter um número de casos proporcionalmente maior do que um país onde as pessoas não tenham tanto acesso aos testes para confirmar o caso de Covid. Então, não é um bom indicador. Segundo, a taxa de letalidade serve, portanto, para falar sobre a gravidade de uma doença. Uma doença que tem uma taxa de letalidade de 20%, de cada 100 casos, 20 morrem, é mais grave do que uma que tem uma letalidade de 5%. De cada 100 casos, somente 5 morrem nesse caso. Então, ela não tem relação com endemicidade ou epidemia. O que define, como a nossa diretora falou no começo, a situação de endemicidade é de uma doença que acontece de maneira continuada. Vamos dar um exemplo, a tuberculose é uma endemia, né? Nós temos várias outras doenças infecciosas que são endêmicas, enquanto que há doenças infecciosas que são epidêmicas, ou seja, produzem surtos, um crescimento grande de casos, depois reduzem, aparecem de novo com outro pico. Essas são características diferentes. Então, a taxa de letalidade não serve para identificar se muda para endemicidade ou não. Sobre a questão da produção de casos mais graves ou menos graves com a Ômicron, o doutor Silvan Aldiguieri já respondeu bem. Os dados iniciais nos mostram que, aparentemente, a Ômicron produz menos casos graves que as outras variantes, porém, como ela se transmite muito rápido e de maneira muito forte, ela pode e está sobrecarregando serviços de saúde e, por isso, é preciso ter muita atenção, colocar os planos de contingência, monitorar bem como está a situação. A Ômicron também produz mortes e os dados que a nossa diretora falou no princípio confirmam isso. Não se deve pensar que a Ômicron é a Covid produzida pela Ômicron é uma doença leve, igual a um resfriado, porque, principalmente para pessoas mais vulneráveis, elas podem, sim, também desenvolver formas graves e vir a morrer. Obrigado.
Muito obrigada, Dr. Barbosa. We take questions from Reuters now. Anthony Bodel, the correspondent of Reuters in Brazil, asks, how serious are the post-COVID symptoms that you are seeing in the Americas? What percentage of people who had COVID are suffering from long COVID? And what are the most frequent symptoms? And what do you recommend governments to do to prepare for this? Dr. Aldigueri, maybe you can give us an answer.
Yes, of course. And we have not observed in the Americas any different patterns, clinical patterns for long COVID as compared to other regions, including Europe, where you have a very strong clinical database. And this is the first point. The second point I'd like to include is that patients having Omicron or recovering from Omicron have exactly the same likelihood of developing long COVID as other patients infected by other variants. The exact burden of the long COVID and the exact proportion of cases that would develop long COVID is something that would require more studies. And I think that Dr. Barbosa, in his answer in the question in Portuguese, has already alluded to, because we have a lot of asymptomatic persons or people with a very mild presentation, clinical presentation, that can develop long COVID also. So we need some more solid data investigation that are not reflected in the regular surveillance system. And the last comment would be regarding the preparedness of the health services, because you have a wide range of clinical symptomatology that would be part of the COVID, the long COVID, including cardiovascular, including neurological, including psychological symptomatology, and others. And we are strongly recommending to have a very comprehensive approach and multidisciplinary approach of this, including clinicians, psychologists, and people in charge of physiotherapy, rehabilitation of patients, exactly. And this will be a burden during the coming years for the health services. So in conclusion, a very solid, comprehensive and multidisciplinary approach for managing these patients at all the levels of care. I hope I have answered the concerns of a journalist based in Brazil. Thank you.
Thank you very much, Dr. Aldigueri. Pasamos a una pregunta desde Violeta Villar de la Web de la Salud. Pregunta, quisiéramos una actualización sobre cómo avanza la denominada supervacuna contra todos los coronavirus y si pudiera ser una respuesta para el fin de la pandemia. Dr. Barbosa.
Não, graças pela pergunta. Há muita expectativa de uma vacuna, e alguns o chamam de supervacuna, que pudiera primeiro ser muito efetiva para todas as variantes do vírus, segundo que pudesse, de preferência, brindar uma proteção permanente, né? Todavia, isto está em processo de desenvolvimento. Temos alguns candidatos a essas vacinas, pero que se encontram em fase pré-clínica, ou seja, todavia estão em testes em laboratórios, para que depois seja possível ter os ensaios clínicos. Pero déjeme subrayar uma coisa, as vacinas que já estão disponíveis são super vacinas também, porque salvaram e todavia estão a salvar milhões de vidas em todos os países do mundo. Então, enquanto esperamos uma vacuna, quizás em 1 ano, 2 anos, 3 anos, vamos a utilizar bem as vacinas que já estão disponíveis, porque elas podem reduzir os casos graves, podem reduzir as mortes, como todos os dados que temos em países de nossa região e em países do mundo estão a demonstrar sem nenhuma dúvida. Então, vamos aproveitar bem as super vacinas que salvaram tantas vidas que já temos hoje. Graças pela pergunta.
Gracias, Dr. Barbosa. Llegamos al final casi de nuestra sesión. Tenemos tiempo para más una última pregunta de Alejandro Arcos de Plenilunia. Asks advances in he asks for what are the advances in the development of infrastructure in the region for the manufacture of PPE, vaccines, and medicines to better face the next stages and health challenges. Dr. Etienne, the last question for you, please.
Well, thank you for this question. You know that was one of the greatest concerns, certainly with the Secretariat in PAHO, the whole question of access, timely access, equitable access to vaccines, medicines, and supplies. So we continue to address this limited production and the unequal distribution of vaccines in the Americas by developing regional hubs to produce, first of all, mRNA vaccines in the future. So an independent committee of experts has selected 2 projects, the public producer Biomanguinhos Institute of Technology on immunobiologicals at the Oswaldo Cruz Foundation in Brazil, and the private company Synergium Biotech in Argentina, that will receive the technical support from PAHO and WHO to accelerate the development and production of mRNA vaccines in Latin America and the Caribbean. So work on this is continuing, but production has not yet started. But let me add that the agreement is that vaccines, the mRNA vaccines that will be produced will be regional goods. And so that all of the countries across the region would have access to those vaccines through the revolving fund. Let me just say that vaccine availability at the global level has increased in recent months. And the PAHO's revolving fund is procuring additional vaccine doses directly from manufacturers and offering competitive prices to our countries. The revolving fund also offers quality vaccines for numerous other diseases and that form part of our routine country immunization programs, and the revolving fund has been doing this for more than 40 years and has successfully facilitated the high coverage and elimination that we've seen of several of those diseases. Recently, PAHO welcomed the WHO listing of an AstraZeneca vaccine that was jointly produced by Argentina and Mexico. And that's the first such decision for a COVID-19 vaccine manufactured in Latin America. The vaccine is jointly manufactured by Argentina's Abscience, which reproduces its active pharmaceutical ingredient, and Mexico's Laboratorios Lioma, which mixes and finishes the product for distribution. Another of our mechanisms is the PAHO Strategic Fund, and this is a regional mechanism for the pooled procurement of medicines and strategic health supplies, and which has been operational for more than 20 years. It has supported 38 million people by producing COVID-19 related products, including masks, gloves, gowns, and other personal protective equipment, as well as diagnostic tests and critical care medicines. So there are 34 countries and territories and 16 health agencies that participate in the strategic fund. And we have procured over $610 million worth of these supplies. These are mechanisms that were established by our member states, and the Secretariat manages these mechanisms. They were primarily established to ensure exactly that, more equitable access to medicines and supplies. The strategic fund initially concentrated on medicines for HIV, TB, malaria, and after that expanded to some other diseases, particularly neglected tropical diseases. And now we have begun the purchase of medicines for chronic diseases. but also we this fund, the strategic fund, purchases supplies of all kinds that are so essential to ensuring adequate and safe health services. And we've continued to do that and amplified that work in COVID-19. So this is where we are. We are working with various partners to ensure that we can ramp up very quickly the work that would lead eventually to this production reality in our region. Thank you for this question again, and let me give my sincere thanks to all of you who have joined this press conference. More so, let me thank you for the work that you do in ensuring that there is wide coverage of the material that we've covered here. And thank you for your continued interest. Thank you so much.
Thank you very much, Dr. Tien. This is a good way to end. I'm sure the colleagues appreciate your support to the work that they're doing. Los periodistas llegamos ahora, se pasan más de una hora de la sesión y llegamos al final. Claro, quedamos atentos a solicitudes o preguntas de seguimiento. Nos pueden enviar al correo mediateam@paho.org. Muchísimas gracias por acompañarnos hoy y nos vemos la próxima semana y espero con mucha salud. Muchas gracias.